Good evening, everyone. I welcome you all for this Neurosciences Forum on the occasion of the month of September. In this month, we are having the Alzheimer's Day. That's why we have selected as the Alzheimer's topics only, mainly. And I welcome all the participants and I welcome the today's speaker, my professor, Dr. V.G. Ramesh sir, and Dr. G. Ramkumar sir for accepting our invitation to give a nice lecture. Today, we will have the program in the form of first talk will be given by Dr. G. Ramkumar sir on Alzheimer's and other types of dementia. And second topic, our professor Dr. V.G. Ramesh sir will give a talk on dementia, neurosurgeon's perspective. And at the end of the two topics, discussions will be there for the panel discussion. And also we will be asking quiz questions. And I request all the participants to be alert and attend the program and answer the questions and get away the prizes. So I welcome you all for this nice session. And first I like to introduce Dr. G. Ramkumar sir. Dr. G. Ramkumar is a new consultant neurophysician from Erode. He is practicing since 2007. I had the opportunity to work with him at Lotus Hospital in Erode. He is attached to his own setup of RKR Neurospecialty Hospital. His main areas of interest is stroke management, Alzheimer's management. He performed more than 100 thrombolysis procedures. He is also an eminent speaker in various forums. His RKR Neurospecialty has all the requisite facilities for handling neurologic related ailments, conditions, and emergencies. The areas of interest are Alzheimer's, stroke, Parkinson's, and epilepsy. So I welcome Dr. Ramkumar sir to give your lecture. Welcome you, sir.
Dr. Rajesh Prabhu sir for a great welcome. So thank you very much for giving an opportunity from a small area from Erode. And thanks for your great kind words, sir, towards me. Thank you very much, sir. And I welcome all the great speakers, all the students and the PGs and our professor Ramesh sir. I'm just a small neurologist here. So we'll start a talk, sir. Dementia is actually, as Sir said, this month is Alzheimer's Day month, and so we talk about dementia as a general condition. Dementia is a term for a loss of memory, language, problem solving, and overthinking abilities. And that's where the everything to interfere with the daily life. It is caused by a number of diseases that damages the brain and destroy the nerve cells. Out of the dementia, Alzheimer's is the most common type. One
second, sir. The slides is not moving. One second.
So we have the DSM criteria for dementia. The development of multiple cognitive deficits manifest by both. So dementia, now the latest criteria is the DSM-5 criteria, where the memory impairment, ability to learn new information or recall the previous information. The second criteria is one of the following cognitive disturbance. It may be aphasia, that is the language disturbance, apraxia, that is the inability impaired ability to carry out the motor activities despite intact motor function, and agnosia, failure to recognize the identified object despite the sensory intact, and disturbance in executive functioning, that is planning, organizing, sequencing, and abstracting. The cognitive deficits in criteria 1 and A2 and A1 causes significant impairment in social and occupational functioning and represents a substantial decline in previous level of functioning. The course is characterized by gradual onset and continuing cognitive decline. So the other part of the criteria is the cognitive deficits of criteria A1 and A2 are not due to the following. It should not be a central nerve system disease or a Parkinson or a Huntington's or a subdural hematoma or a normal pressure hydrocephalus or a brain tumor. The systemic conditions that causes dementia like hypothyroidism, vitamin B12 deficiency, folic acid deficiency, niacin, and hypercalcemia, neurocephalus, and HIV infections. The substance abuse should also be ruled out before labeling it as dementia. The deficits do not exclusively during the delirium. The delirium should not be taken into the criteria. By another access disorder like the psychiatric disorders like major depressive disorder or schizophrenia. The DSM-4 criteria for mild cognitive impairment. So evidence of modest cognitive decline from previous level of performance or cognitive domains like complex attention, executive function, learning and memory, language, perceptual, motor, and social cognition based on concerns of individual and knowledge informant that have been mild decline in cognitive function, a modest impairment in cognitive performance. It may be standardized by neuropsychological test or absence of other qualified clinical assessment. The cognitive deficit do not interfere the capacity of independence in everyday's activity like complex instrumental activities of daily living, and managing medications are preserved. An effort compensatory strategies or accommodation may be required. The cognitive decline should not occur exclusively in the context of delirium. The cognitive decline should not be explained by another mental disorders. So the type of neurocognitive domain, what we consider in the dementia is perceptual motor function, like visual perception, contextual reasoning, perceptual motor coordinations. Executive functions, it should be planned, the planning, decision making, work memory, responding to feedback inhibitions, and flexibility. Complex attention, like sustained attention, divided attention, selective attention, and processing speed. Social cognition, that is recognition of emotions, theory of mind, insight. Learning and memory, free recall, cued recall, recognition memory, semantic and autobiographical, long memory, and implicit memory. Languages like object naming, word finding, fluency, grammar, and syntax receptive languages. So what are the simple ways of dementia? It may be a memory loss or short-term memory changes. It may be a difficulty in concentrating and focusing. It may be difficulty in carrying out normal routine tasks. It may be a confusion with a time or a familiar place. It may be a frequent mood changes. It may be a misplacing things frequently and failing sense of direction. The 10 forms of dementia, what we commonly look at is Alzheimer's is the most common, followed by vascular dementia, that is due to the vascular insults, and Lewy body dementia due to the degenerative part of brain, and Parkinson's disease due to Lewy body deposits, and frontotemporal dementia. It's also type of degenerative one, and Crook-Jackfield's disease. It is due to prion disease, and Wernicke-Korsakoff syndrome due to the alcoholics, and normal pressure hydrocephalus, which are one of the most treatable dementia, and Huntington's disease, one of the degenerative dementia, and mixed dementia is due to degenerative plus vascular dementia combination. So just I talk about the Alzheimer's. The description is commonly the brain cell death. Most commonly, at least 60 to 80% of the cells will die. Where the symptoms will be the memory confusion, mood changes, and trouble speaking. The key facts are affects the older age adults. Whereas the vascular dementia, there will be a reduced blood supply to the brain up to 20% minimum. There will be usually confusion, concentration issues, visual problems linked to strokes or atherosclerosis. Lewy body dementia, it is a protein clumps, disturbs the brain signals. The memory loss and hallucination, sleep issues. It shares the symptoms with Alzheimer's and Parkinson's disease. The Parkinson dementia, advanced Parkinson has got dementia. They have a reasoning issues, confusion, hallucination, and speech problem. Occurs in later stages of Parkinson's disease. Whereas frontotemporal dementia affects the language, behavior regions of the brain. So they have predominantly they have behavioral changes, loss of inhibition, and language issues. Can start as early as 45 years of old. Creutzfeldt-Jacobs disease is a prion disease. It's a rare prion dementia. The memory loss will be common, the muscle twitching and stiffness, and along with confusion. It is fatal within 1 to 2 years, and it is 1 per million cases. Wernicke-Korsakoff syndrome is usually linked to vitamin B1 deficiency seen in chronic alcoholism. It is associated with memory problem, learning disability, and coordination loss. Not true dementia. It is not a true dementia, but similar symptoms will be there. Normal pressure hydrocephalus, fluids build up in the brain ventricles, and it's a poor balance, memory disturbance, and mood swings and bladder issues. That is a triad. And can be reversible with surgery. Huntington's disease, it's a genetic cause. It's a nerve cell breakdown. There will be associated jerky movements, speech issues, impulse control disorders. Symptoms starts usually as early as 30 to 40 years. It's early in juvenile form also, juvenile Huntington's. Mixed dementia almost equal to Alzheimer's because it is most of the dementia what we are nowadays seeing in the present world, a combination of degenerative plus vascular. There will be a vascular insult due to diabetic, hypertension, and cardiovascular disease, along with that underlying degenerative changes in the brain. So varies often difficulty with speech and movements, and the percentage unaware doesn't have 45% of the people unaware that they have a disease itself. So simply we generally stage the 1 where there will be a normal cognitive functioning in 7 stages of dementia, stage 1. And stage 2, loss of familiar objects, unable to recall the loved ones. Stage 3, get lost while driving, forgets the birthday or appointments. Stage 4, withdraws the sociality, struggles within everyday's tasks such as cooking. Stage 5 is forgets the information of events, may wander somewhere. Stage 6 requires assistance with activities of daily living, pronounced memory loss, and stage 7 lacks coordination, affecting the ability to walk and eat. So since Alzheimer's, I'll just touch the topic. Alzheimer's disease is the most common type of dementia. It's a progressive disease beginning with a mild memory loss, possibly leading to loss of ability to carry out the conversation and respond to the environment. Alzheimer's disease involves a part of the brain and control thought, memory, and language. So prevalence is around 70% of all dementia cases, and age groups around 65 to 75%. So country in the number of dementia cases are increasing because we have a long survival rate. So from last 2019, from on towards to the 2050, we have more dementia cases because of extra large surviving population in the elderly age group. The Alzheimer's disease continuum. So the preclinical Alzheimer's disease, in the preclinically, there will be no symptoms, but possibly biological changes in the brain starts. The mild cognitive impairment, what we have discussed in DSM-4, DSM-5 criteria, there will be a mild symptoms and may not interfere with everyday activities. Dementia with Alzheimer's disease, which is mild, the symptoms interfere with some everyday activities. Dementia due to Alzheimer's moderate type, where the symptom interfere with many everyday activities. Whereas the day-to-day activities are more severely affected. So this is the difference between the healthy brain and Alzheimer's brain. The neuron structures in the healthy brain are intact, whereas the neuron loss, tangles, and damaged connections. There will be an amyloid plaques accumulation in Alzheimer's, absent in the normal aging brain. The brain size will be shrunken, particularly in the hippocampus in the Alzheimer's. The brain size will be normal. Cognitive functions, impaired cognitive function and confusion in Alzheimer's, whereas stable cognitive function in normal brain. The neurotransmitters, there will be a lot of decreased levels, especially acetylcholine level in Alzheimer's disease. The memory functions will be significantly lost, especially short-term memory in Alzheimer's, whereas the long-term and other part of memory will be retained in the late stage. So this is Alzheimer's symptoms. It may be confusion with the time and location, the difficulty completing the familiar task, misplacing the items, difficulty in solving the problems. It's a memory loss, poor judgment, unfolded emotions, trouble with images and spaces, and difficulty in words and withdrawal from social activities. This commonly we see in Alzheimer's. So the neuropathology in Alzheimer's is already we know it is amyloid plaques, alpha beta pleated sheets. So and associated neurofibrillary tangles, and along with that neuroinflammation and mitochondrial dysfunction in the cell, and autophagy and dysfunction, and cholinergic insufficiency finally. So neuroinflammation plays a critical role in the pathogenesis and complex interaction between the cellular and molecular components of the brain and the peripheral immune system. And there is a dysregulation in the neuroinflammatory pathway, such as glial cells, including the microglia, astrocytes, and along with other inflammatory cells. The hyperactivation contributes to significant progression of the Alzheimer's, promotion of the chronic inflammatory environment of the brain. So microglia and astrocytes, these cells release the inflammatory mediators response to the amyloid beta plaques, exacerbating the neuronal damage. Peripheral immune infiltration, like dysfunctional blood-brain barrier, allows the peripheral immune system to enter the brain, enhancing the inflammation. Cytokine storm, excessive production of inflammatory cytokines like interleukin-1 beta, interleukin-6, and tumor necrosing factor alpha, which derives a chronic neuroinflammation. And complementary system activation leads to neuron loss, although synaptic burning by microglia. So generally, it's a neuroinflammation followed in the neurons with the microglia, along with cytokine, chemokine, and leutrokines, with hyperphosphorylated tau and amyloid plaques. So which ends with the dementia. So in group, this is the dysregulation is a pathway like NF-kB, P38, MAP, and TAR, mTOR, and caspase, nitric oxide, and COX, which acts on the astrocytes, microglia, and other inflammatory cells. Along with that, PPAR receptor agonist, COX inhibitors like vitamin E, C, curcumin, and candin. All this involves in the neuroinflammation and produces Alzheimer's disease. So, diagnostic approaches for all dementia. We use commonly mini mental scale. Advantages is it is popular and a great number of testing results are available. It's concise and simple and highly specific and accurate, and various cognitive functions can be assessed. The limitation depends upon highly on the language outcomes because it is in English, and doctors can face financial challenges because we have to explain the patient and the attenders. Quite limited in individuals with visuospatial difficulties because we cannot able to draw the diagrams, and low sensitivity, unable to accurately predict the future disease development. These are the limitations. And we have other scales to modify the dementia calculators. Montreal Cognitive Assessment covers a wide range of cognitive function freely available to use, has various tests, visuospatial ability, and short time. The scores can be affected by sensory deficits. That is the limitation in Montreal scales. So we also have investigations like computer tomography for dementia to identify it's a low price and high accessibility, where exposure to radiation and less sensitive than MRI and resolution is poor and limited distinction between white and gray matter. That's the difference in the CT scan for identifying dementia. CSF studies, we have a lot of biomarkers coming into that, low cost in various countries, able to analyze the neurodegeneration like tauopathies and inflammatory markers are there, but sample size and collection is invasive. But despite the limitations, CSF biomarkers are not available at present in a lot of our countries, in many places. And regular for frequent CSF analysis is not feasible. A normal CSF profile indicates absence of AD, should not be ruled out. So now the newer investigation process like PET scan, where they have metabolic changes detected in the PET in Alzheimer's disease, and PET is suitable for patients who cannot undergo lumbar puncture. We can identify the alpha beta 42 proteins. PET examination is quite expensive. That is a limitation. It lacks spatial resolution and radiation exposure is unavoidable. MRI is also very good. It is applicable and expensive. The availability is high. It is expensive process, but slow scanning speed, suffers from motion artifacts, no molecular specificity. Some patients have those with pacemaker and heart stents and what is the aneurysm clips we cannot use. The SPECT, the single photon emission tomography used for also assessing dementia, better than and quite costly, and exposure to radiation is also there. So the mild cognitive impairment in Alzheimer's, the duration is 7 years. The disease begins with a medial temporal lobe. From last 7 years, then the patients will present with a mild cognitive impairment. The mild Alzheimer's, the duration will be 2 years. The disease spreads to the lateral temporal and parietal lobes. The symptoms will be reading problem, poor object recognition, poor direct sense. The moderate Alzheimer's, the duration will be 2 years. The disease spreads to the frontal lobe. Symptoms, reading problem, poor object recognition, poor direct sense. Severe impairment, duration will be 2 years. The disease spreads to the occipital lobe and symptoms, visual problems also starts. This disease, it may be cognitive function decline. It may be from a normal aging, preclinical, mild cognitive impairment, and dementia, depends as the years goes on. The treatment is here. What? Because for the degenerative dementias like Alzheimer's, we have to treat the trouble with the familiar task, unfolding the emotions, trouble following the conversation, difficulty with the works, confusion with the time or place, and memory. So we have to target what the patient requires and what the caregivers wants to take care. So drug-wise, we have approved drugs in dementia are For symptomatically FDA approved, we have Donepezil, Galantamine, Rivastigmine, Memantine, and Donepezil. So out of this, we at present in India, we have Donepezil, Rivastigmine, Memantine, and things. So all these are acetylcholine inhibitors, whereas Memantine is NMDA receptor antagonist. So there are some uses. Donepezil with Memantine combination proves very useful. Combination with disease modifying therapies, like we have started working with amyloid cascades. These are the trials which are going on, where we can block the BACE inhibitors. Amyloid monoclonal antibodies are developed, and alpha beta vaccines are coming. And we have tau aggregates, tau active immunization, tau passive immunization. And others, we have got the newer studies which are going with tyrosine kinase inhibitors, RAGE, anti-inflammatory, and angiotensin blockers, and list of treatments goes on. The combination with symptomatic therapies are, we can treat symptomatic more with agents like 5-HT receptor antagonist and MAV inhibitors, anticonvulsants, melatonin, serotonin receptor agonist, and glutamine neurotransmitter modulators, for which it can target the cognition, agitation, aggressive, and non-convulsive seizures in dementia, which can target these problems. So choline esterase is the best drug, still from the long use, which inhibits acetylcholine, the enzyme responsible for breaking down acetylcholine, and the neurotransmitters critical for memory and learning. Associated with decreased acetylcholine in Alzheimer's and the brain important for memory. So out of this, Donepezil is the best drug. Donepezil inhibits acetylcholinesterase, thus increases the concentration of acetylcholine at cholinergic synapses. Approved by Alzheimer's in all stages, mild, moderate, and severe, available in 5-10 milligram tablets, and extended release up to 23 milligrams. The side effects includes nausea, diarrhea, insomnia, cramps, fatigue, and weight loss. And mostly well-tolerable drug. Dosage, it starts from 5 milligram daily, titrate up to 10 milligrams and maximum 23 milligrams. So Rivastigmine, its mechanism inhibits both acetylcholinesterase and butyrylcholinesterase, thus increasing acetylcholine levels at the synaptic level. Butyrylcholinesterase inhibition may enhance the effect, and mild to moderate Alzheimer's we can use, and milligrams it available in capsules, 1.33 and up to 6 milligrams. Nowadays, we are also having an oral solution because some dementia patients are IL-2 fed, and we can have transdermal patches in later dementia, and side effects are the common side effects with skin irritations and anorexia and headaches. The dosage, initial starting from 1.5, increase maximum to 6 milligrams per day, depending on the tolerable capacity. Galantamine, at present we don't have in India, inhibits cholinesterase, also modulate nicotinic receptors, enhancing release of acetylcholine, potentially improving the cognitive function. Mild to moderate Alzheimer's we can use. The available dosage are 4, 8, and 12, and side effects, mostly the sleep disturbance compared to and bradycardia. The dosage schedule starting from 4 milligram twice daily, 12 milligrams daily can be extended. The NMDA receptors are now better. They modulate the activity of glutamate. Excitatory neurotransmitters play a role in memory and learning. So it's best tolerated in Alzheimer's. Excessive glutamate activity can lead to neuronal damage. So Memantine blocks the NMDA receptors, preventing excessive stimulation of glutamate, helps to protect the neurons from excitotoxicity. Moderate to severe Alzheimer's we can use. Available in 5 milligram and 10 milligram dosage, oral suspension, and extended release tablets up to 28 milligrams. Side effects, confusion and constipation, hypertension and hallucination should be watched. The dosage, immediate initial starting dose 5 milligram daily, titrate weekly, and extend up to 28 milligrams daily. So always dementia is treatable by multifactorial, particularly Alzheimer's. So what the core symptoms they want? So cholinesterase inhibitors we can use. Antipsychotics if the psychotic symptoms are predominant, like hallucination, delusion, agitation, aggressive, we have to do antipsychotics. And if that is a mood disorders like depression, apathy, emotional withdrawal, anxiety, we use antidepressants like TCA, SSRI, SNRI, and tricyclic antidepressants. And if it is a cognitive impairment, memory loss, we can use Memantine more. And the antidepressants, what we commonly use are citalopram, escitalopram, sertraline. So starting 10 to 20 milligrams, citalopram, sertraline 50 to 100 milligrams daily. The mechanism works increasing the availability of serotonin as a neurotransmitter that modulates the mood and emotional response. Antipsychotics, we can use risperidone 0.5 to 2 milligram per day, olanzapine 2.5 to 10 milligrams per day, and quetiapine 25 milligrams to 200 milligrams per day. The mechanisms, it blocks the dopamine in the brain, which helps to reduce the agitation and psychosis. However, they carry the black box warning, so strokes and LND can also have Parkinson features. So amyloid targeting therapies are now started to come into the dementia treatment. So anti-amyloid treatments like clinical research are going. So we have, this is the newer drug which come into the FDA approval for Alzheimer's dementia now. That is Aducanumab. It's a monoclonal antibodies that targets aggregated forms of beta amyloid, promoting the clearance from the brain. Still, we have to get it from India. That's used in mild cognitive impairment to mild Alzheimer's. That is a dosage. Intravenous infusion is available. The side effects are amyloid-related imaging abnormalities because they use the MRI for the amyloid plaques and also the PET scan and SPECT to identify the brain edema and swelling and microhemorrhages during the antibody usage. Depends on that, we can start the infusion. So it starts with 10 milligram per kg body weight by IV infusion every 4 weeks. And other newer drug which has come to the market in treating Alzheimer's is Lecanemab. So it is another monoclonal antibody that binds with protofibrils of the amyloid beta to prevent the plaque formation and remove the existing plaques. So early stages, including mild cognitive impairment and mild Alzheimer's disease. The formulation, once again, it comes in intravenous and similar to the same side effects like we also watch for amyloid-related imaging abnormalities should be watched because they have a cerebral edema, they have microhemorrhages and dizziness. And every dose before you infuse, starting, you have to do an imaging and followed by completion and before starting the next dose. The dosage is 10 milligram per kg body weight every 2 weeks by IV infusion. So the emerging trends with the future, we have gene therapy and genetic modifications. These are all in trials. We have CRISPR, Cas9. This is an Alzheimer's, this is a gene editing process where we can edit the gene like amyloid beta buildup and control the amyloid plaque formation. And adenovirus associated vectors we can use, which can target directly to the amyloid plaques and the top proteins and prevent the Alzheimer's progression. And the neurotropic factors like brain-derived growth factors, neurodegenerative may survive the disease progression. So also we have now antisense oligonucleotides, which have already come into the market, but it's a very costly process where we can block the RNA interface. The technology, it's a slicing of RNA, is like a editing of the RNA. We can cut the slice which required part of the RNA and inhibit to the production of the amyloid beta or a tau at the mRNA level before it forms the plaques or the tangles. The antisense oligonucleotides, these are the newer one which come to the market. It's used in other part of degenerative brain disease and neurodegenerative disorders like SMA. But now it also enters a place into the Alzheimer's disease. It's a synthetic molecule to bind RNA and prevent the production of harmful proteins. In Alzheimer's, they are being developed in targeting tau protein production, and some antisense oligonucleotides based therapy already in clinical trials for neurodegenerative, as we said, in SMA, it has already started using in all over world. So we have also alpha beta vaccines, amyloid beta vaccines, which can design to trigger the immune response to clear the amyloid plaques before they accumulate. And tau vaccines are also available, and they started presenting papers. The newer one, the neural stem cell therapy, replacing the lost neurons in the disease, and transplantation of neural stem cells restore the function and improve the cognition, and induced pluripotent stem cells also used, which can be reprogrammed to become any cell type, including the neurons. This also started trial in Alzheimer's disease. So before just finishing that, we have to look after what are the rapidly progressive. Whenever dementia progresses rapidly, what could be the signs we have to find, and why could we have to establish that one? The rapidly progressive dementias are progress quickly and course within weeks to months, but sometimes in 2 or 3 years. Compared to the regular dementia and Alzheimer's, which are all degenerative, which takes years together. The progression of the rapidly progression from patient to patient, the part depends on the underlying cause. So once you suspect a rapidly progressive dementia, suspects disease like prion disease, that is CJD, autoimmune condition, because we have a lot of autoimmune encephalitis are coming into, and paraneoplastic syndromes are coming into, and infections like HIV and all type of viruses, including syphilis and HIV. So diagnostic challenges, the shift of progression requires urgent evaluation to rule out treatable causes, because some of them are treatable like autoimmune, some are treatable like paraneoplastic syndrome, and some infections we can be treated with antibiotics and antiviral. So understanding what is the predominant symptom in rapidly progressive. It may be a confusion and memory loss. It may be a depression, movement disorders and seizures, headache, apathy, and flu-like symptoms. This gives a clue that is not a degenerative dementia. Whereas rapidly progressive dementia is a rare form. The symptoms occurs within days, weeks, and months, as I said. And how to receive the diagnosis? So hospital to test the clinical and physical and neurological examination, cognitive assessment with MMSE and Montreal scale, and blood workup, depending on the function, depending on the etiology, what you suspect, from thyroid profile, rheumatological analysis, paraneoplastic analysis, and infection analysis, and autoimmune analysis. Along with that, you do a urine analysis and MRI of the brain. So this sir will be talking, surgeons. Treatable dementias are cognitive impairment that may be reversed and improved with a proper treatment. The key examples are normal pressure hydrocephalus. It's very well treatable by shunting. Vitamin B12 deficiency
ஓபன் பண்ணிட்டு வாங்க.
treated with B12 supplements. Hypothyroidism treated with hormone therapy, replaced with thyroid hormones. Alcohol-related dementia, stop alcohol and nutritional support. Infections, we have treat like HIV and syphilis, antiviral and antibiotics. And pseudo-dementia, always think, because many of the dementia with nowadays, it looks like dementia, but it is not a dementia. Managed with antidepressants, the patient will improve. And brain tumors can be treated with surgery and radiations, so I will talk about it. And medication side effects, like some drugs will also produce dementia, managed by adjusting the dosage and stopping the medications. So importance of early diagnosis, we have to timely intervene, timely do the effectiveness, improved patient outcomes, informed decision making, and reduced research advancement. This will be the future early diagnosis of the dementia. So first we prevent it, optimal treatment outcomes, enhanced quality of life, planning for the future, and contribute for the research planning. Thank you.
Dr. Ramkumar sir, for your nice lecture. We will have the questions and at the end of the second talk. Now we will invite our professor, Dr. V.G. Ramesh sir, to give his lecture on the neurosurgeon's roles perspective in dementia. Professor Dr. V.G. Ramesh is my teacher. I'm proud to be one of his students. And he has done MCH neurosurgery and DNB general surgery and DNB neurosurgery and FRCS in England and Glasgow. He is Professor Emeritus, Department of Neurosurgery, at present in Chettinad Hospital, Research Institute, Chennai. Senior neurosurgeon with over 4 decades of neurosurgical experience, neurosurgery teacher for nearly 4 decades and postgraduate examiner for MCH, DNB, FRCS, and neurosurgery in India and abroad. Has several publications in neurosurgery journals and authored chapters in neurosurgery textbooks. Major contributions include Madras Head Injury Prognostic Scale, Madras Institute of Neurology IMIN method of CSF outflow measurements, studies in trigeminal neuralgia. I invite our Professor V.G. Ramesh sir to give his lecture.
Good evening, Rajesh, for a nice, very liberal and generous introduction. And I was very much overwhelmed by your invitation to give this lecture. And I also thank Dr. Ramkumar for nicely giving a lecture on Alzheimer's disease and many of the facts which we still don't know. I have been asked to talk about dementia from the point of view of neurosurgeon. Dementia is a severe cognitive dysfunction. It has been elaborated by Dr. Ramkumar. It is the impairment of global intellectual function, including memory deficit and difficulty in learning new skills, difficulty in concentration and taking personal decisions affecting daily life. This is a very important thing. The normal mild cognitive dysfunction may not be known as dementia, but dementia, the term dementia indicates a more severe form of cognitive decline. Coming to neurosurgical causes of dementia, it include mass lesions, destructive lesions, and hydrocephalus. I will deal one by one. Mass lesions, especially in the frontal and temporal lobes, especially in the dominant hemisphere, both intrinsic and extrinsic mass lesions can present with cognitive impairment. Frontal basal tumors like olfactory groove and convexity meningiomas and glioma affecting the frontal and or temporal lobes. Then chronic subdural hematoma, either unilateral or bilateral, present like a slowly expanding extrinsic mass lesion. And infective granulomas like tuberculomas, especially multiple tuberculomas, multiple fungal granulomas, and multiple neurocysticercosis. All these can present like dementia, present as dementia. These mass lesions can affect attention and concentration, executive functions, speed of thinking, social cognition, learning and memory, communication skills, vision, and perception, which have been elaborated by Dr. Ramkumar. The type, degree, and rate of progression on prognosis of cognitive dysfunction or dementia is related to the location of the lesion, whether it is intrinsic or extrinsic, the rate of the tumor growth, pathology, whether it is benign or malignant, the type of surgery, and also the need for adjuvant and radio chemotherapy, which also may affect the dementia. And coming to the mass lesions, the frontal lobe mass lesions, prefrontal lesions can affect the personality, attention, concentration, executive function, social behavior, such as and can cause disinhibition and emotions, labile emotions. Premotor deletions can affect the motor function pattern, and the Broca's lesion, Broca's area lesion can affect the language production. Temporal lobe lesions may affect the memory, retrieval of information, language comprehension, like the Wernicke's dysphasia, and expression behavior. Parietal lobe lesions can affect the processing of memory, sensory information, orientation, etc. Occipital lobe function lesions can affect the interpretation of visual stimuli. But a tumor in one area can affect, or area or lobe can affect the cognitive dysfunction of the other lobes also, because of the association fibers which are connecting the various lobes. High-grade gliomas and metastasis cause rapid progression of the cognitive decline in a short span of time, whereas low-grade gliomas, meningiomas cause a very slow and gradual cognitive impairment, which may present over a few months or some years also sometimes. And many a time the impairment is very subtle, especially in meningiomas. The tumor removal and reduction of the pressure on the brain causes improvement in the cognitive dysfunction, and almost there may be reversal of the dementia. But there can be worsening of the cognitive dysfunction, especially with the intrinsic mass lesions, because of the post-surgical swelling or edema, but usually in long term it recovers. Radiation therapy can cause cognitive dysfunction due to radiation-induced brain edema in the acute phase or due to radiation necrosis months or years after the radiotherapy. Chemotherapy, presence of seizures, and anticonvulsant medication also can contribute to dementia in these patients with tumors after treatment. This is an example of a 45-year-old man who had recent onset headache, memory disturbance, and right-sided limb weakness. MRI contrast shows large intrinsic tumor, the temporal lobes, and the temporal lobe on the left side with edema and mass effect. Patient was operated and the histopathology showed astrocytoma grade 2. Patient's neurological status remained static post-operatively. He didn't show much improvement. Whereas this is an example of a 54-year-old lady who had headache, apathy, memory disturbance, and right-sided limb weakness of a few months duration. And MRI showed a large left frontoparietal parasagittal meningioma with edema and mass effect. After craniotomy and excision of the tumor, patient showed complete neurological recovery, and the higher functions of memory were normal after a month after surgery. Mass lesions like bacterial infections, fungal or parasitic granulomas, especially multiple lesions, can cause varying degrees of cognitive impairment. 12 to 15% of patients with multiple neurocystic psychosis may develop severe cognitive dysfunction bordering on dementia. These are mostly reversible with appropriate treatment. All these granulomas, parasitic infections can be reversed with appropriate drugs. So they are eminently treatable. Chronic subdural hematoma is one of the other common diseases which we see in the neurosurgical practice. It's one of the common causes of treatable and reversible dementia. About 54% of patients of chronic subdural hematoma present with cognitive impairment. The patients usually are in the older age group and may present with recent onset or subacute cognitive decline. There may be a history of some trauma to the brain, either trivial or months or weeks to months before the presentation. This is a 64-year-old man who presented with rapidly progressive cognitive impairment and right-sided limb weakness within 10 days. He had a trivial fall at home a few months, 2 months earlier. MRI shows a large left frontoparietal chronic subdural hematoma with mass effect. Patient show completely recovered with cognitive and neurological dysfunction almost immediately after evacuation of the hematoma. Just he needed burr holes and evacuation of this subdural hematoma. It's one of the very rewarding surgeries in neurosurgery, and patient almost recovers completely. The other side of the neurosurgery, where we see traumatic, destructive lesions causing, dementia. Especially the traumatic brain injury is one of the common causes of dementia. After a large focal contusions result in gliosis, scarring of large areas of the brain, especially involving the frontal and temporal lobe, more often present with varying degrees of cognitive impairment, especially with behavior and memory disturbance, which may last for many months to years. Maybe sometimes it recovers, sometimes may continue to remain like that. Diffuse injuries also can cause, diffuse axonal injuries also can cause varying degrees of cognitive dysfunction. Short-term memory impairment is seen in the immediate post-traumatic, in the period of post-traumatic amnesia, especially with the concussion, which is transiently characterized by confusion, disorientation, and amnestic memory impairment. But it usually recovers in shorter time because there is no structural damage to the brain. Another important lesion is the subarachnoid hemorrhage, which is caused by rupture of intracranial aneurysms, which carry 30%, the 30-day mortality of 30 to 40%. 50% of survivors of subarachnoid hemorrhage have significant cognitive dysfunction bordering on dementia. Risk factors for development of cognitive impairment are generalized cerebral edema, left-sided cerebral infarction, Huntington's has grade 2 or more, thick subarachnoid hemorrhage in the anterior interhemispheric fissure and sylvian fissure due to anterior communicating artery and middle cerebral artery aneurysms. Hydrocephalus is the next common cause of neurosurgical cause for dementia. Childhood hydrocephalus causes mild or no neurological deficit. Usually they don't affect mental function that much. Severe mental retardation is very rare. It's only maybe there is mild impairment only. But if the severe damage in severe mental retardation can be due to associated brain damage or other damage, because of other infection or vasculitis, things like that. Adult hydrocephalus may be due to obstructive hydrocephalus, like due to intraventricular tumors. Commonest of which is the colloid cyst of the third ventricle, which can present with dementia. Communicating hydrocephalus, post-meningitic, post-traumatic hydrocephalus, and normal pressure hydrocephalus are one other common cause of cognitive impairment and dementia. In colloid cyst of third ventricle, the cognitive impairment is related to the hydrocephalus itself or to the due to the bilateral damage to the fornix by the colloid cyst. Those patients in whom the bilateral damage to the fornix could be demonstrated in MRI have impaired memory and poor performance on tests of learning and recall. Then coming to the major topic of the day, the normal pressure hydrocephalus. The normal pressure hydrocephalus is a triad of cognitive decline or dementia, gait disturbance, and urinary incontinence, which occurs in adults, old adults. It may mimic the other cause of cognitive decline in adults like vascular dementia, Alzheimer's disease, etc. Normal pressure hydrocephalus offers a potential reversible cause of cognitive dysfunction, and hence there is a need for differentiating normal pressure hydrocephalus from other causes of dementia. The mechanism of cognitive impairment in normal pressure hydrocephalus are many. Some of them are mechanical distortion of the periventricular white matter and in corona radiata, corpus callosum, and compression of the subcortical gray matter structures like hippocampus, caudate nucleus, thalamus, etc. Intermittent changes in the intracranial pressure and CS of pulsatile, increased CS of pulsatility causing impaired cerebral perfusion also can cause dementia. The hyperdynamic CS of flow during the cardiac cycle across the aqueduct, along with the loss of elasticity of brain due to dilated ventricular system, causing hammer-like effect on the upper brainstem, causing damage to nuclei like substantia nigra, result in Parkinsonism-like syndrome, and also dementia. Interstitial edema, which is seen in the periventricular areas of shown in the imaging, may be a cause of dementia or the other features of normal pressure hydrocephalus. The normal pressure hydrocephalus involves frontal subcortical structures causing impaired attention, reduced speed of information processing, and impairment of phonemic verbal fluency and executive functions. Whereas Alzheimer's disease involves cortical structures, defects in semantic language, calculation abilities, and other cortical functions. Diagnosis of normal pressure hydrocephalus is challenging because of its close mimics. As I told you about the vascular dementia and Alzheimer's dementia. In normal pressure hydrocephalus, the gait disturbance sets in earlier than the other symptoms of the triad, and it is more severe and disabling. Gait disturbance most predominant. Cognitive dysfunction and dementia bordering on frank dementia is very rare in pure NPH. Only usually there is a mild cognitive impairment, which is reversible. Sometimes it can be mild to moderate to severe also, but we can cause confusion with the Alzheimer's disease. Bladder symptoms occurs later and is usually mild in most cases of normal pressure hydrocephalus. Radiology, diagnosis is mainly radiological, where the several features which are most important are ventriculomegaly out of proportion to the cortical atrophy. The frontal horns are rounded in contrast to beaking in case of cortical atrophy. The temporal horns are more prominent in normal pressure hydrocephalus. Periventricular translucency is seen in frontal and occipital regions, but periventricular leukoencephalopathy and microangiopathy also can mimic this. Aqueductal flow void, which is best seen in T2 weighted MRI, also because of the increased flow of the CSF across the aqueduct. These are the other features like narrowing of the sulci in the high cortical cuts and see here, and a narrow callosal angle, which is less than 90 degrees, and Evans ratio is more than 30 degrees, 30.3. So these are the features which can differentiate normal pressure hydrocephalus from vascular and Alzheimer's dementia. So this is the aqueduct flow void where you see the aqueduct, there is a black area in the aqueduct. This is the aqueduct flow void, and this is a periventricular translucency which you see in normal pressure hydrocephalus. still when they, I mean, with the now the phase contrast MRIs, the CSF flow studies are becoming very popular using a phase contrast MRI. Increased aqueductal flow rate more than 24.5 ml per minute is diagnostic of normal pressure hydrocephalus. And more importantly, the increased aqueductal CSF stroke volume more than 42 microliters, I mean, also indicates the normal pressure hydrocephalus and predicts a good outcome after shunt. CSF studies are also very important in CSF dynamics, especially, are very important for part in diagnosis of normal pressure hydrocephalus, where the diagnosis is still uncertain. CSF opening pressure is one of the important things where the lumbar puncture is done. Measurement of opening pressure is used. Opening pressure is measured using a saline manometer. The elevated CSF opening pressure may suggest normal pressure hydrocephalus, but normal or lower CSF pressure do not exclude normal pressure hydrocephalus. If it's elevated, it's good, but it's low or normal, still you cannot exclude normal pressure hydrocephalus. Other popular test is the CSF tap test, where we drain about 30 to 50 ml of CSF and assessing for improvement in gait. Though the improvement in gait favors the diagnosis of normal pressure hydrocephalus, absence of improvement does not rule out normal pressure hydrocephalus for certain. So here is the role for CSF dynamic studies. It's one of my favorite areas of research of this. I have done some research on this, and these are done to measure the CSF outflow resistance, and it is very useful in the diagnosis of normal pressure hydrocephalus and also predicting the outcome after shunt surgery. There are various methods of measuring the CSF outflow resistance: constant pressure infusion test, constant flow infusion test, bolus lumbar infusion method, and I use the modified method, Marmoros bolus lumbar infusion method, which I have named as MIN, Madras Institute of Neurology method. It's a very useful bedside tool for which good clinical application, and it's now being used widely, especially in our place. This is a very simple method. Anybody can do it. I think can start doing it. This is a very simple method of measuring the outflow resistance using readily available material and not requiring any costly or sophisticated equipment, and can be performed within a short time. You need about 10 to 15 minutes only maximum. Saline manometer or improvised one is made using a IV set mounted on a meter scale, and you can fill it up with saline up to 11 centimeters of water from the zero level corresponding to the level of the spine. Lumbar puncture is performed with a 20 gauge needle, spinal needle, and connected to the saline manometer through a three-way adapter. After the CSF column stabilizes, the opening pressure is measured. The known volume of saline, usually 5 to 10 ml, is injected to the subarachnoid space through the three-way port, and the rate of 1 ml per minute, 1 ml per second. And the peak pressure reached after the bolus injection is noted. And once the saline column, the manometer starts falling gradually, after a fixed time, say 5 to 10 minutes, the pressure recording is done with the pressure reading on the manometer is done. And this outflow resistance is calculated using a two-step formula. Now it can be done very easily with the calculators, and these are the two steps. First step, we measure the pressure volume index, and second step, we measure the CSF outflow resistance, and this is converted into millimeters of mercury by dividing by 1.36. The normal value of CSF outflow resistance in normal Indian population ranges between 6 to 9 millimeters of mercury per ml per minute. The mean of 6.1. It is not this CS outflow resistance is useful not only in diagnosis of non-pressure hydrocephalus, but also other disorders of CS absorption, and also in deciding whether success of shunt surgery, where especially in cases where NPH and severe cortical atrophy which coexist. CS outflow resistance more than 18 millimeters of mercury per ml per minute, and this is more suggestive of, and more is suggestive of predicts a favorable outcome after shunt surgery. So this is an example of normal pressure hydrocephalus where there was a 45-year-old man presented with memory disturbance, gait disturbance for since 8 months. Neurological examination showed he had a moderate degree of dementia with memory deficits, and he had slow ataxic gait. The CT scan brain showed moderate degree of cortical atrophy and ventriculomegaly, but the diagnosis was uncertain whether it was normal pressure hydrocephalus or Alzheimer's. The CSF dynamic study was performed, and the outflow resistance and opening pressure was 17 centimeters of water, only mild increase, and by our bolus injection method, clinched the diagnosis of normal pressure hydrocephalus. So we did a shunt, VP shunt, and the patient's symptoms, both gait as well as the dementia, recovered remarkably. So the take-home messages are cognitive dysfunction can be caused by variety of diseases, neurosurgical diseases. They include intracranial tumors and mass lesions, destructive lesions, and hydrocephalus. Intracranial mass lesions, especially the extraaxial ones, chronic subdural hematoma, normal pressure hydrocephalus, represent a treatable and reversible cause of cognitive dysfunction and dementia. I thank Rajesh Babu, Dr. Ramkumar, and East West Pharma, and also all the members of the audience for the patient hearing. Thank you.
Participants have any question, they can directly ask the speakers.
Sir, is it any biomarker available, sir, for early detection of Alzheimer and dementia?
Yes, sir. There is a lot of biomarkers we can do nowadays. CSF studies, sir.
Yeah.
Like beta amyloid sheets, tauopathies can be assessed, sir, in the CSF. And like prion disease, we can assess prion levels. And we can do neurofibrillary tangle levels, sir. This can be premonitory. We can find out in patients with preclinical symptoms. But the data says how far we are able to identify and what are the population we are going to take, and how to select the population which we are feeling, sir. Like a family history is there, senile dementia or Alzheimer's disease, that group of population we select. But in a general population, to select which group to be assessed like this. And since we don't have much treatment process, so committing this to the patient or attender is also question mark, sir. But there are 3 or 4 antibody CSF to test it, like alpha beta sheets, amyloid 1, and prion disease can be assessed. Neurofibrillary tangles can be assessed, sir, to get the premonitory symptom before the onset of dementia. It all will be raised in the dementia patients, sir.
Now, now we will have questions from Professor Ramesh quiz. First question, you can put it.
Yes, sir. 1 second, sir.
Yes, sir. Question number 1.
In chronic subdural hematoma, dementia cognitive impairment is seen in what is the percentage? Actually, Professor V.G. Ramesh sir has given exhaustively in detail about dementia, the causes, and the neurosurgeon's role in dementia. Only one doubt from the audience is that while doing the VP shunt based on the normal pressure hydrocephalus, straight away we can proceed with the VP shunt, or we have to do any preferential tests before that and do the VP shunt, sir. Ramesh sir?
I
Sir.
didn't follow your question. Just can you repeat?
Sir, while doing for the normal pressure hydrocephalus, we are doing the VP shunt now, sir.
Yeah.
So straight away we can do the VP shunt, or we wait for the any preliminary procedures, do it, and then proceed with the VP shunt, sir.
See, when the diagnosis is certain, but both clinically and imaging wise, you are convinced that with the diagnosis of normal pressure hydrocephalus, with the features I mentioned, where the gait disturbance is more predominating than the dementia, and also the narrow callosal angle, then the crowding of sulci in the top cuts. If there is aqueduct flow wide, then you can proceed straight away with, VP shunt. If you still have a doubt, many cases it's not straightforward. Many times the imaging may be dubious. It can be mimicking both. So in such cases only we need to do CSF studies like either a tap test or a outflow resistance measurement, which will confirm the diagnosis. Then we proceed with the shunt. The diagnosis straightforward, no problem. We can do shunt straight away.
Sir, in the shunt, we have to do the programmable shunt, or we have to do the regular shunt procedures.
Programmable shunt is very much indicated in normal pressure hydrocephalus, but when in Indian circumstances, the cost of programmable shunt is little high for affordability for our Indian patients. So many times we use fixed pressure shunt, fixed pressure valve shunts, especially the low pressure valves. But ideally speaking, programmable shunt should be done in normal pressure hydrocephalus.
Now you can put the second question from Dr. Professor Ramesh's talk. In neurocystic sarcosis, severe cognitive dysfunction is seen in what type of percentages? Thank you, both of you, for allotting some time for our invitation and giving the lecture. Thank you, sir.
Thank you very much.
Thank you.
Thank you very much. Thank you.
Thank you so much, sir. We extend our heartfelt gratitude to our course director, Dr. V. Rajesh Babu sir from Ganga Hospital, Coimbatore, and a lucid presentation and experience shared by Professor Dr. V.G. Ramesh, and also we extend gratitude to Dr. Ramkumar sir As definitely the lecture will be useful for our PGs, and the edited version will be available shortly in our East Coast Pharma YouTube channel. So you can contact our East Coast field force, sir. So the same type courses will be continued for our benefit of the PGs, sir. And external gratitude to all of the delegates also participated in the programs. Thank you so much, sir.